Okay, hello everybody. This is the monthly quiz. Let's get started right now. Hope everybody is having a great day. I do have a bunch of cases for you. Hopefully, you will find them interesting. So let's take a look at what we got. First case, cough and fever. You can see there's a mass in the right lower lung. Kind of looks a little bit strange for pneumonia. It's perfectly round. And then in the image on your right, there's a tubular structure going to it. And if you look at the venous imaging, you can see that tubular structure is a vessel. And if you follow it down, you can see it's coming off the aorta. So now you have a mass or some process that appears to be enhancing, and there's a feeding vessel off the right side of the abdominal aorta, which you can see very nicely on the 3D imaging. That's a classic appearance for a process which is a sequestration of the right lower lung. Looks like a mass, can be confused with pneumonia or even a tumor, but then you very nicely see it with the feeding vessel. We talk about sequestrations. Systemic blood supply is critical, typically defined as intralobar and extralobar. They're considered congenital. The extralobar has its own pleura, typically in neonates, typically on left side, and the intralobar shared pleura, more common in adults, again left side more common. Systemic arterial supply and pulmonary venous drainage. Extralobar is usually asymptomatic, which is why it presents in adults. Intralobar is more symptomatic, so it will present earlier in life. So just some comments about sequestration. Look for that feeding vessel. Again, you need to think about it because otherwise you're going after the differential of a mass or pneumonia. A very important case. Okay, right upper quadrant pane, there's a mass, 10.7 centimeters. On this scan, it could be kidney, could be adrenal, could be anything. Here it is enhancing, and this is an adrenal lesion. It's enhancing, it's cystic, and it's solid. Obviously easier to tell on the coronals where it's arising from. So what are we thinking about? It's a large mass. You got to be thinking about things like adrenal cortical carcinoma, metastasis in the right clinical scenario. Maybe because it's enhancing and necrotic, pheochromocytoma is a possibility. You're not thinking about adenomas or myelolipomas. You're thinking ACC pheometastasis. A few more looks at it, and this was a pheochromocytoma. Pheos commonly will bleed. This lesion has probably bled. Pheos, we tend to think about them as being very vascular, but when they're larger, they can be more cystic, they can be more necrotic. Really nice example of a pheochromocytoma. Next case, 30-year-old with back pain. Again, sticking with that adrenal theme, there's a mass by the left adrenal gland pushing on the kidney. Same differential, adrenal cortical carcinoma, pheochromocytoma, metastasis. This was a very unusual case. Again, you're not thinking adenoma, you're not thinking myelolipoma. This was eventually resected. Again, the thought was this was a primary adrenal cortical carcinoma and it was a neuroblastoma. Now you say, wait a second, neuroblastomas are only in young patients. Well, they can occur, rarely, in adults. And in fact, way back when, wow, that's like 41 years ago, we wrote this article on 5 adult patients with neuroblastoma. So again, it's possible it can be confused with ACC or lymphoma, but again, it is in that differential diagnosis. Another case, right adrenal mass. It's solid, again, pheo, lymphoma possibly, often bilateral, ACC, solid mass. Give contrast, there's some prominent vascularity. Now, when I start seeing irregular vessels like this, I'm always thinking about neoplasm. I'm thinking about an ACC. I also would mention some of the rare sarcomas, We've had angiosarcomas or other sarcomas of the adrenal, though they're exceedingly rare, but they typically have neovascularity. This is not going to be a benign process. This was eventually resected. You can see it here again on the washout, and was a primary adrenal cortical carcinoma. Really nice example. GI bleed, there's a submucosal mass in the stomach that's high density. Yes, it could be calcification, but it's probably enhancing. What things occur in the stomach that enhance? Adenocarcinomas and most polyps are typically hypovascular. GIST tumors can occur in this location and can be vascular. You can see glomus tumors. You can see pancreatic RES or ectopic pancreatic tissue. You can see metastasis. I have a couple cases of metastatic renal cell carcinoma. Again, very smooth, well-defined, submucosal in nature, and this was a really nice example. There's the endoluminal view from the Vert colon software, and this was a glomus tumor. Again, think about carcinoid, think about glomus tumors, think about pancreatic RES, but pancreatic RES usually are not submucosal, so that would make that much less likely. GI bleed, what do I see here? At the level of the junction of fourth portion of duodenum and GIST, and the, not GIST, and the jejunum, there's a large ulcerating tumor. You can see it there. Things I think about, primary tumors. I think first of adenocarcinoma. Doesn't look like carcinoid. GIST usually is exophytic, not circumferential. Could be lymphoma. Could be metastatic disease, or good possibilities with this bulky ulcerating lesion of the junction of duodenum and jejunum. This was eventually biopsied and resected and was a classic duodenal adenocarcinoma. Really nice example. What about this case? Prominent, thickened distal small bowel, really prominent vas recta. Could think about ischemia, infection, inflammatory disease, Crohn's disease is a possibility, drug reaction is a possibility, a range of things. It doesn't look neoplastic, it looks infectious, inflammatory. You can see the cross-sectional appearance. And this patient, the diagnosis was related to chemotherapy, drug-related. This was a patient with rectal cancer and pancreatic cancer. This was a severe enteritis. Just again, a really nice example of how impressive enteritis could be. We just published an article in Emergency Radiology on this topic that's worth reading. Hematuria. There's some fullness by the left renal pelvis. Again, you want to be careful. Sometimes things are not as obvious as on the arterial phase. And here, if you look carefully, image on your right or even left, there's something filling in the pelvis. This could be blood, but you got to worry about a tumor, and you will begin to see it better as you go later on. And here it is on Venus. You can see it. It's slightly enhancing. It's filling in the calyx, extending into the pelvis. And of course, you would expect to see this really nicely, and you do on the excretory phase imaging. So what are you thinking about? Mass infiltrating the renal pelvis, involving and probably arising from the lower pole calyx. This is a classic example of a transitional cell carcinoma of the kidney. A really, really nice example showing the value of multiplanar reconstruction and also the importance of delayed phase imaging, particularly in detecting and defining transitional cell carcinoma. There it is again. Okay, what else? Pelvic pain, complex cystic mass. Yes, you're going through the differential, this female of ovarian cancer. Dermoid, doesn't look like quite, I don't see any fat, but multiple septations. Could be a tubo-ovarian abscess with the right history. That's a definite possibility with all these cystic changes, okay? Complex septations. Well, ovarian cancer is a thought. Tubo-ovarian abscess is a thought. Another possibility would be endometriosis. Endometriosis is a great mimicker, can look like malignancy, can look like infectious disease and inflammatory disease. You always need to think about endometriosis. Another case, abdominal pain, mass in the mesentery, dense calcifications, bowel is not obstructed. There's a slight desmoplastic reaction, looking at the branches off the SMA. The differential diagnosis here is sclerosing mesenteritis versus carcinoid tumor. You can get masses in the mesentery of nodes calcify following treated lymphoma occasionally, but I didn't give you any history. Carcinoid and sclerosing mesenteritis can be difficult to distinguish. Obviously, if you see a mass in the bowel, you see liver lesions, you're going with a carcinoid tumor. We always talk about desmoplastic reaction being carcinoid, but it does occur in sclerosing mesenteritis as well. You put everything together, here it is on the cinematic, and this was sclerosing mesenteritis on biopsy. Again, it can be a very challenging diagnosis. Well, that's 10 cases. I hope you enjoyed them. I hope you learned something, and I hope you have a great day. And from all of us at CTisus, have a great day, everybody.